Hello, I'm Irene Kang, medical breast oncologist at City of Hope in Orange County, California. I'm joined here today with Dr. Aditya Bardia. Dr. Bardia, would you like to introduce yourself?
Absolutely. Hi, I'm Aditya Bardia. I'm a breast medical oncologist at UCLA, and I'm excited to talk about HER2-positive breast cancer with Dr. Kang.
Great. So first, we'll set the scene and discuss the historic standard of care. So for metastatic HER2-positive breast cancer, there's been a long-standing historic standard of care, first reported by the Cleopatra trial in 2012, which was taxane with trastuzumab-pertuzumab, followed by trastuzumab-pertuzumab induction. And this regimen demonstrated really impressive progression-free survival benefits, as well as overall survival benefits that persisted with long-term follow-up. So this has really become the standard of care for the past 10 plus years. And this strategy and philosophy of induction therapy with taxane and trastuzumab-pertuzumab, followed by maintenance with HER2-targeted antibodies, has been the sort of operating standard of care. Dr. Bardia, what do you see as the current unmet needs in the first-line setting for metastatic HER2-positive disease?
Absolutely. So we tend to use THP in the first-line setting for patients with HER2-positive disease, but you can run into issues in terms of side effects. Taxanes can increase liver enzymes. You have some patients who have residual neuropathy, and because of that, sometimes we struggle with the chemo portion related to the THP. Brain metastases, that's another big unmet need in this patient population. And then eventually patients have disease progression, and majority of them. So from an unmet need perspective, it is therapy that would have lower toxicity, particularly less neuropathy, could treat or could prevent brain metastases, and also improve progression-free survival and overall survival.
That's the type of therapy we need. I've also seen a statistic that up to 30% of patients don't even make it to second-line therapy. How does that impact sort of the gravity of choosing first-line therapy to you?
Absolutely. In general, that's a principle in oncology. We use the most effective agent as early as possible. That's true for HER2-positive disease, for metastatic TNBC as well. Now, you were talking about attrition rate. With every line of therapy, there's a subset of patients who don't get to the next line.
Thank you. Can you now share with us the DESTINY-Breast09 study and sort of how that what the findings were?
Absolutely. So DESTINY-Breast09 was designed to look at an antibody-drug conjugate called trastuzumab deruxtecan. It's an antibody-drug conjugate that binds to HER2 and then has 8 deruxtecan payload molecules attached to it. And the idea is to deliver deruxtecan, which is a very potent TOP1 inhibitor, to cancer cells and thus induce apoptosis and cell death. So in DESTINY-Breast09, T-DXd was evaluated against THP. The trial had 3 arms. THP was control, T-DXd was the second arm, and third arm was T-DXd plus pertuzumab. At ASCO 2025, we saw the results of DESTINY-Breast09. In the first-line HER2-positive MBC setting, T-DXd plus pertuzumab was superior to THP in terms of progression-free survival. The progression-free survival was getting close to 4 years. It was about 3.5 years, and clearly significant in terms of both statistical significance as well as what we call the results were clinically meaningful. Now, one thing to note in DESTINY-Breast09 was that patients just continued T-DXd. It was not 6 or 8 cycles and you stop. Patients continued T-DXd plus pertuzumab. While with THP, we sometimes do THP 6 cycles, stop, and then continue HP maintenance.
So there was no maintenance on the T-DXd plus P arm.
Correct. And while there was no maintenance, you saw an improvement in progression-free survival, trend towards improvement in overall survival as well.
Absolutely. I saw also that there were really higher overall response rates than THP. And interestingly, higher complete responses in the T-DXd arm. Do findings like that sort of compel you to think about, this choice differently, a higher rate of complete response?
Absolutely. So the results were very impressive of DESTINY-Breast09. You saw improvement in PFS, trend towards overall survival, a higher response rate. If you look at the forest plot, it's very impressive. Pretty much every patient has some degree of decrease in the tumor. And I think the objective response rate, which is more than 30% reduction, was close to 80%. It's very impressive in terms of how active this drug is as compared to THP, where the response rate was lower. So where would response rate matter? It would matter in a patient who has symptoms, and I want a quick response, or I want to reduce their disease burden. Then we know T-DXd is a good agent that would do that. Also, in terms of brain metastases, we have data from DESTINY-Breast12 that patients who have brain metastases, T-DXd works in that setting. And so potentially by using T-DXd in the first-line setting, you can prevent brain metastases. It's almost like primary prophylaxis against brain metastases.
That's such an important point with brain metastases being such a high incidence in metastatic HER2-positive disease and a huge impact on really prognosis as well as quality of life. I saw in the DESTINY-Breast09 publication that the 12-month CNS progression-free survival for the subset of patients that had inactive brain metastases at baseline was an impressive, 60% 12-month progression-free survival. So it does sort of mirror that activity in the CNS that we've seen in later line studies.
And which becomes really important for patients, because if a patient has brain metastases and it increases, they would have symptoms.
Absolutely.
It can cause nausea, it can cause headaches, it can cause neurological deficit. So it's important to have an agent that works in that setting.
We'll go on to then sort of making these treatment decisions. Which patients do you think are appropriate for the DB09 sort of treatment strategy as opposed to historic standard of care THP?
T-DXd in this setting is not FDA approved yet, but let's say it is FDA approved, then that would be an option I would consider because of the improvement in PFS, overall survival that we've seen. So I would consider, and it does not cause peripheral neuropathy either. So overall does provide an advantage over THP. So I would consider T-DXd as a first-line therapy option for patients with metastatic HER2-positive breast cancer. The open question at this time is, do you continue forever, or after some cycles, can you stop T-DXd and then switch to HP maintenance? So use T-DXd more as an induction therapy and then use HP as maintenance therapy. That is being evaluated in a clinical trial, the DEMETHER clinical trial. So that'll give us more information whether that's a strategy we can consider in the future.
It's a great point. Yeah, I would agree. I think, the subgroup analysis showed really consistent benefit with the T-DXd plus P sort of approach over standard of care. And so, yeah, it sounds like you don't have a patient population that you would not consider it for in the first-line setting if it were available and appropriate to use.
Yeah, pretty much, yeah. There are not many contraindications to T-DXd. I guess if a patient has baseline lung disease, so COPD or pulmonary dysfunction, we do know that T-DXd causes pneumonitis. So that might be a patient population where upfront I would not consider T-DXd, but other than that, that would be the preferred first-line option.
I think we talked about this, but what makes early use important in your mind? Because there may be folks who are hesitant to start as first-line therapy.
I think there are three things to consider. The first is what we were talking earlier in a patient who has symptoms, and patients sometimes when they present with de novo metastatic HER2-positive disease, they present with symptoms, then you need an agent that can decrease symptoms, that can decrease tumor burden. So in that setting, an agent like T-DXd can be very beneficial. The second thing to consider is the complete response rate. We have some patients who have complete responses to first-line therapy. It's lower with THP as compared to T-DXd, but that's complete remission. And if a patient could have complete remission, that's, from a prognosis perspective, a very good prognostic factor. And we don't have biomarkers at this time who can predict who would have complete response versus not, and you would only know after you've started the treatment. The third thing to consider is the neuropathy. Some patients have baseline neuropathy from diabetes or other prior treatment, and that's where T-DXd can be valuable or helpful.
Yeah, I found that sort of durable remission, durable response was reported in the study, and doubling of complete response also. And I found that very compelling that, everyone deserves a chance to reach for the stars in terms of outcomes. So yeah, I would agree. I'm planning to use the DB09 approach quite broadly. How about, we talk about real world decision making. These are all, of course, shared decisions when we're talking with patients. What are the benefits and risks that you plan to discuss with patients?
Absolutely. With any therapy, we talk about efficacy and then we talk about the toxicity profile as well. We reviewed the efficacy in terms of toxicity profile with T-DXd. When I talk to a patient that I'm going to start T-DXd, I review the side effects. I start with nausea. That's the number one side effect with T-DXd. And when I talk about any side effect, I also talk about supportive therapy or how to manage or prevent that. And we can come back to the specific management of these AEs. The second one is some degree of myelosuppression. So I tell them that we'll be monitoring toxicity with blood work. The third is some degree of diarrhea. And I tell them that if they have this side effect, there are medications that we can provide. And then finally, I do warn patient about the serious, rare but serious side effect of pneumonitis with T-DXd. The incidence is 10 to 15%, but the key is if a patient is having any symptoms, they should let the provider know. Because for symptomatic pneumonitis, if that progresses, that could be very dangerous.
Certainly. And I think, with all of us having longer experience using T-DXd in later line settings, et cetera, we are more comfortable with the monitoring and we can address that shortly. It does seem to me that for most patient interactions, that sort of efficacy, especially in the first line, is going to be so important. And so generally this sort of risk-benefits discussion sways heavily towards what is going to get you the longest survival. And I think you're right, side effects can be managed, especially prophylactically or ahead of time. And there was really fascinating PRO's data presented at the rapid fire session that you moderated for DB09, suggesting that, at least for patient report, there was no difference in PROs for, THP versus continuing T-DXd plus P, as a...
Absolutely.
Yeah.
And often, PROs are complex because if a patient is having symptoms because of the disease, if you control the disease, then that would help reduce that symptom and could improve quality of life. But then you can also have side effects from drugs which can impact PROs. And so the key then becomes management of those side effects.
Balancing that.
One of the things to consider with PROs, and that was discussed in the session also, is sometimes in clinical trials, they just measured at the start of a cycles. They might not fully capture what a patient is feeling in between cycles. So we just need better metrics for measuring that as well.
That's certainly an ongoing need in the field. So, getting to tolerability and adverse event management, how do we keep patients on therapy? How do we make patients sort of have the best quality of life as well as get, the best effective drug? What has your overall experience been using T-DXd, and how do patients tolerate it?
So there are many patients who, once you start T-DXd, as long as you use a 3-drug antiemetic regimen, and then you warn them about diarrhea, they can use loperamide to manage diarrhea, they don't have any problem. They can continue with the 5.4 milligram dose every 3 weeks of T-DXd. But then there are some patients who have a difficult time with T-DXd in the first cycle, the second cycle. These side effects usually come on early. And so in that circumstance, you can up the supportive therapy or you can even consider a dose reduction. So I often say it's the right dose for a patient rather than the highest dose. We just have to find what's the best dose for an individual patient.
Yeah, and I find that there's significant patient variability in terms of tolerability and who experiences the nausea and fatigue to what extent. I have patients who I think are older and frail and do extremely well on T-DXd with appropriate prophylaxis. And then, young fit patients who have a very hard time with the nausea and fatigue sometimes as well as diarrhea. So I think it is about, appropriately starting that cycle 1, but also managing actively with subsequent cycles. We talked about you feeling that nausea is sort of a major side effect to actively manage in this drug. Let's get to more specifics. How do you manage nausea? What is that 3-drug regimen you're using?
No, absolutely. So in general, I start with 3 medications to prevent nausea. So that's primary prophylaxis. So one would be a 5-HT3 antagonist like paloncetron. The second one would be an NK1 antagonist, something like Imand or fosprepitant. And the third would be dexamethasone. So that's the triplet regimen that I use initially to prevent nausea, vomiting. And if a patient is doing very well, then you can peel off, like remove the decadron.
Sure.
There are some patients who will have breakthrough nausea despite this. And in that setting, olanzapine seems to be a pretty good medication. Chlorperazine can be used, but olanzapine appears to work very well for nausea with all these ADCs, not just T-DXd, but other ADCs as well. So that's more of a breakthrough medication that can be used in this setting.
That's great. Yeah, that's certainly the approach I take as well. And olanzapine seems to help for a lot of patients. Occasionally, if someone has anticipatory nausea, do you use Ativan?
Absolutely. For anticipatory nausea or anxiety, Ativan, lorazepam works very well.
Great. Fatigue is something that was shown in the study to be, more profound with patients on T-DXd plus P compared to THP. Are there any strategies to manage that?
I think looking at the labs, some patients might have anemia, so that's something that's fixable.
Major.
Looking at the thyroid levels, patient could have hypothyroidism, not necessarily related to the drug per se, but in general. So once you've treated the reversible causes of fatigue, things to consider would be a dose reduction. And again, fatigue could be related to the dose. So if you decrease from 5.4 to 1 dose level lower, that could help with fatigue.
This is truly an area that I think we need to help patients with better. I think what we've got out there, some data for exercise, and then really much less sort of a quality of data in terms of pharmacologics that might assist patients, but certainly an unmet need too. Okay, the major one that I think affects providers really quite deeply as well as patients, ILD and pneumonitis. What's your strategy for monitoring patients on therapy?
With CAT scans. So when a patient is treated with T-DXd, we get CAT scans at baseline, and every 8 to 9 weeks, that's my frequency. And I'm not only looking at response, but also looking for evidence of pneumonitis on scans. Because if a patient is asymptomatic but has pneumonitis on scans, the recommendation is to hold T-DXd even for asymptomatic ILD and start steroids. So it's very valuable to monitor this with scans because that's an actionable finding.
Yeah, and I think this sort of management strategy is, I think, the most aggressive, I'll say, for all the other sort of side effects that we deal with, but so important to make sure that this is a safe therapy for our patients. Any other sort of side effects that kind of you find you have to deal with? You mentioned diarrhea, actually.
Yes, diarrhea can be seen with T-DXd. Loperamide tends to work well. And then also alopecia. The drug does cause alopecia. There's a question about cold caps. In general, we've not seen much efficacy with cold caps with T-DXd. At SABCS 2025, our group would be presenting results based on our experience with cold caps related to T-DXd, and essentially there was not much benefit with cold caps related to alopecia from T-DXd.
It's too bad.
The Dana-Farber group also has a phase 2 trial, and I think their preliminary results are also very similar, that these cold caps don't work that well with ADCs. And part of this could be because the payload is released over time, unlike chemotherapy, and cold caps are only given for a fixed duration of time.
Out of the available ADCs we do have in the clinic, though, it seems that the alopecia with T-DXd is less, would you say?
As compared to SG, yes.
Okay, we talked about weighing adverse events against efficacy when starting a patient in the first line. Do you feel that any of these adverse events really would sway you away from T-DXd in the first line?
Not necessarily, as long as you're ready to reduce the dose. You will have some patients who, when you start T-DXd, they start having this chronic nausea or fatigue, and you're going to have a question about, I just want to discontinue this drug. Before discontinuing, consider a dose reduction, 1 or 2 dose reductions. Often you'll see in clinical practice that once you reduce the dose, the patient experience gets better.
Is there a point where you would discontinue and switch to a maintenance trastuzumab pertuzumab strategy?
After a few
clinical trial,
cycles,
yeah.
no, that's an open question. I would want to see some data from DMETHER. If that looks good, that's certainly something to consider. Or if a patient is really struggling, like chronic nausea or fatigue, and they've received at least 6 cycles of T-DXd, then I would feel comfortable switching to HP and then just monitoring them on HP with the understanding that if the disease increases, I can bring back T-DXd again.
It sounds like a great practical strategy while we wait for data. For a patient who's doing really well on T-DXd plus P, so the DB09 regimen, would you consider just continuing therapy until progression, or would you consider otherwise, like a maintenance strategy?
In general, if the patient is tolerating the therapy very well, you could continue. But if there are side effects, then one could switch to maintenance strategy. So that's something that's more driven by patient experience and discussion in terms of the side effect. In terms of a patient who has complete response or complete remission, at some point, should you stop T-DXd? I think that's an open question. It's similar to HP. Here and there, we do have patients who have no evidence of disease or complete response. And then should you stop HP or should you continue HP? I think these are open questions.
Absolutely. The hope is that, using T-DXd plus P in the first line will get more of these complete responses and long-term remissions. So sequencing after DB09, what comes after your first-line therapy with DB09 regimen?
When a new therapy displaces first line, that becomes second line. So if a patient is on T-DXd and continues T-DXd and then has disease progression, one option to consider would be THP in the second line setting. And then the other options remain. One could use capecitabine plus tucatinib. One could use TDM1. In general, I would not sequence ADC back to back just because we have other options available. So I would personally either consider capecitabine, tucatinib, or would consider THP. Some of these patients will have disease progression because of brain mets. Definitely in that setting, I would consider capecitabine plus tucatinib.
That's very helpful for us sort of taking this data home. Some folks feel that, using T-DXd in the first-line setting is sort of burning through an option. Do you look at this as an opportunity for patients or a barrier to later-line therapy?
No, I think in general oncology, we use the most effective drugs because what if you have a complete response or remission?
Absolutely.
You might not get to a second line. So, as long as a drug is active and patient meets criteria, in general, it's good to use that drug. If a patient has disease progression T-DXd, then you can use a second drug, a third drug, and that's how we prolong overall survival.
Sure, and these other drugs, should have some efficacy, although maybe not as, profound as in the first-line setting, correct?
Correct.
Yeah. And then you mentioned, getting to that second line. As we discussed early on, some patients don't make it to second line, so using that best therapy up front does make sense.
It's a good point.
Do you see any practices with adoption of, newer regimens such as DB09? Do you see any regional patterns, maybe reticence or hesitant to adopt a new therapy?
I'm not seeing any data related to regional practices, but I can imagine if a physician is not very comfortable with T-DXd and has a lot of experience with THP, they might start with THP, reserving T-DXd for the second line. But someone who has experience would potentially consider it in the first line. Now, in the future, we'll have other drugs as well, tucatinib or CDK4/6 inhibitors like palbociclib, and that might further complicate in terms of how these drugs are being used.
Are there any misconceptions you hear about T-DXd and its ability to be used or safety in patients?
ILD, I think there's appropriate concern related to ILD, but it's not at a level where T-DXd should not be used. And the other is this idea that you necessarily have to continue T-DXd forever. If a patient is having side effects, you can consider dose reduction. You can even switch from T-DXd to HP maintenance. That's better than discontinuing the therapy completely.
Sounds great. Yeah, I've seen patients who discontinue T-DXd just because they feel like they need a break and still maintain sort of a long disease control. I haven't yet done the sort of T-DXd induction with maintenance HP yet, but would anticipate that would be fairly effective in many patients. So I think I'll go to kind of other studies and the competitive landscape. Let's contextualize DB09 among emerging first-line and maintenance strategies. Do Do you think, competitors with first-line induction to maintenance designs impact using T-DXd in the first line?
So it's a good question. There are two trials to consider. The first one is Patina. That trial looked at patients who were on THP induction and then switched to HP maintenance. The addition of palbociclib was associated with improvement in progression-free survival. And this was for patients with hormone receptor positive, HER2 positive disease, also called triple positive, by some providers. So in that setting, you could see improvement in PFS. And then at SABCS 2025, we saw the results of HER2CLIMB-05, where the addition of tucatinib to HP, both ER positive and ER negative, was associated with improvement in PFS. Now, neither of these regimens are FDA approved, but if they become FDA approved, then the question would be, if I use palbociclib or tucatinib, do I have to use THP induction, or can I extrapolate and start with T-DXd induction, and when I go to HP maintenance, then consider these therapies? That's an open question at this time.
Yeah, I think practically, I might start with T-DXd plus P, since I think both of those maintenance studies, the Patina as well as HER2CLIMB-05, don't really shed light on what to do for induction. And then if you make it to a maintenance phase, I think you have your pick with maintenance strategies in the right population. But otherwise, I might continue T-DXd plus P indefinitely as long as patient is tolerating. Is that what you would do?
I would do the same. Yeah.
Sounds good. Any elements of these trials, either DB09 or the maintenance strategy studies with Patina or HER2CLIMB-05, that might affect real-world treatment decisions?
I think over time, we'll probably have data from the real-world setting where some providers would be doing this T-DXd and HP maintenance. So besides the DMETHER study, I think the real-world data would be helpful because that can influence clinical practice.
Any other, up-and-coming agents that you see sort of affecting this space of HER2-positive metastatic disease?
In the first-line setting, no. The results with T-DXd are so good that it'll be difficult for any other drug, at least in the foreseeable future, to change that. I think what we need to focus more now is how do we manage the AEs, make the drug more tolerable for patients, maybe a lower dose, better supportive therapy, and also the idea of induction maintenance. That's where the field is headed.
Great point. This is kind of the first change in first-line therapy induction in greater than 10 years, so we have our homework to do. Wonderful. Well, I think we touched on a lot of things. We have some key takeaways that we want our audience to go home with. One is that the DB09 regimen demonstrates a meaningful evolution or a change in the standard of care for first-line therapy in metastatic HER2-positive disease with T-DXd plus pertuzumab. We discussed selection of patients for DB09 and really touched on the fact that we think this is broadly applicable in this patient population, and key to set expectations on adverse events as well as managing and monitoring over time. In terms of sequencing and what comes next, I think we still have all the agents that are already available to us available in the later line setting. There's also maintenance strategies that may be employed if a patient needs to come off T-DXd. So a lot of great options, I'd say. Any closing remarks, Dr. Bardia?
And that's why we do clinical trials, and to see drugs that are improving survival, helping patients live longer, I think is fantastic. We also focus on how to make patients live better. And so the supportive therapy, the focus on quality of life is also very important.
Very exciting to have this. Great, I think that's a wrap. We can redo or assess other stuff.
Go ahead.
I thought you did a really, really great job, so thank you both so much. There was a couple of things I just wondered if you might be interested in discussing. I think you've covered a lot of the piece about Patina and but one of the things is I think people are really presenting it as DB09 versus 05 versus Patina. And sometimes it's not clear that there's different patient eligibility with Patina.
That was the question. Okay.
So I wonder if, while you covered it in different parts of the
can we just address it as a piece?
Home message type piece where you can say, and I would call it Patina and HER2CLIMB because that's what people are referring to as.
Okay.
Is there something you feel comfortable where you could maybe try that as like a one go, like to say, are these interchangeable? And then you could talk about like patient eligibility, and then how, like, I think your point, Dr. Kang, around maintenance versus induction is like, that could be part of that piece. Does that make sense?
Okay, should I maybe propose to Dr. Bardia, like, how do you put all this into context, and he can really say DB09 is sort of its own thing, and, you know, that maintenance studies.
To me, like as one piece versus I think you had all those pieces.
Okay, but maybe as a take-home? Okay.
I'd like do it as like a one take-home.
Okay, great. So when we're putting all these updates into context, Dr. Bardia, we've got DB09, and we have 2 maintenance trials with patina and HER2-CLIMB-05. How do you mesh those together? How do you incorporate these into your practice?
I think they're different. So DB09 was T-DXd and showed T-DXd was superior to THP. And so if the drug is approved, we would use T-DXd in that setting. The patina, as well as the HER2-CLIMB, that looked more in terms of adding a therapy to HP maintenance. So if we use those drugs, it has to be technically be with THP, and then when we switch to HP maintenance. You know, merging them in the future, we at least need some more data before it becomes routine clinical practice.
So really differentiating DB09 as induction and maintenance, or sort of ongoing first-line therapy, whereas the patina and HER2-CLIMB-05 studies were just in the maintenance setting.
That's exactly correct.
That was perfect. And then one other question. You know, we talked a little bit about patient cases. I think you touched on, you know, were the patients that, you know, you put them on even though you thought that they might.
Oh, sure. Yeah.
But I was wondering if there's anything you might want to share about your clinical experience with like from the patient case study perspective, and then maybe in a piece of that as well from a psychological perspective for the patients. You covered the total amount of time with DB09, but I don't think we touched on the delta of an additional 2 years of what that might mean for a patient. So do you know what I'm trying to say? Like, if you can contextualize the data from a patient's perspective psychologically to get an extra 2 years, if they might see that.
Okay.
And then anything else, again, maybe a separate thing about like, you know, kind of any patient cases you had that you're comfortable saying what DB09 might mean to them. Does that? You know what I'm trying to say?
Yeah, for sure.
Putting it from a patient perspective, yeah, I'll just send a text.
Maybe I can say, like, how would you frame the benefit of a DB09 regimen to a patient? Okay. Dr. Bardia, how would you frame the benefits of a DB09 regimen to a patient?
No, it's exciting results. So I would talk to a patient about what we saw in DESTINY-Breast09, that by giving T-DXd on an average, patients were on the drug, 3 to 4 years. And, after that, that's on an average. There are many patients who would be on the drug for an even longer period of time. So if we talk about the prognosis, that's in years when we're using effective drugs like T-DXd. And psychologically, that, provides, patients some perspective in terms of what to expect over the next few years when we're using this drug.
Yeah, how wonderful that we can tell patients, we're expecting years for you, and we're expecting to see even survival that, hasn't even been reported yet. And, some durable responses as well, which I think is so meaningful for patients.
Absolutely.
Okay. That's it. Wrap up. Yeah, thank you so much. And
We right on time. Oh, sorry. Okay. What do I do? Okay.
Joining me, Dr. Bardia, and
Thank you so much for joining me, Dr. Bardia. This was such an incredible discussion and very educational.
Thanks for having me. I enjoyed the discussion as well.
Thank you.
that was great, guys.
Awesome. Great. Right on time.